start.
All right, thanks, Yvonne. All right, everybody. Welcome to our education session this evening, a COPD and asthma, an update for primary care providers. I'm Jo Silver, I'm the GP advisor at Western Health, and together with me this evening is Associate Professor Anne-Marie Southcott, who's our presenter, and behind the scenes we have Yvonne from the PHN who's helping with all the tech support and has helped with the college CPD application. So for those who are present, you'll get your CPD points. So next slide, Anne-Marie. So I'll begin this evening with an acknowledgement of country. Western Health and Northwestern Melbourne Primary Health Network would like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Woiwurrung people, the Boon Wurrung people and the Wathaurong people. We pay respects to elders past, present and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. So just a little bit of housekeeping. Everybody is muted. And if you can ask questions in the Q&A function only, so I keep saying I can't cope with switching between chat and Q&A. The session will be recorded and you'll receive a link to the recording and a copy of the slides in the post-session correspondence, as well as links to any of the resources and things that we may cover off tonight. Just please make sure that you have joined. The name that's showing on your screen is the name that you've registered with. If not, you can try and change it, or you can send Yvonne a message in the chat function to make sure that she knows you're present, and that way she'll be able to allocate your CPD points and send you your certificate of attendance. Next slide. You can make this session count towards your reviewing performance and measuring outcomes CPD. So if you implement a quality improvement change following this activity, you'll be able to claim measuring outcome hours. So just make sure you can log that. And if you continue reflection following this activity, you can use the steps to claim reviewing performance hours. So through your self-log on your CPD portal. Next slide. So as always, we give you an update on the information on Health Pathways Melbourne for the topic that we're covering. So there are pathways for COPD and asthma, and the pathways have been written by GP clinical editors with support from local GPs, hospital-based specialists and other subject matter experts. So they have got lots of information about the assessment and management, and also information on how to refer. And if you go into the how to refer button and click down onto the Western region, you can it'll take you straight through to our hospital referral guidelines. So you've got the consistency of making sure you provide the information, because we all know what a pain it is when you get rejected referrals. So next slide. So this is what the health pathways will look like. And as you can see on that left-hand side of your screen, a whole lot of the respiratory pathways there. So, and you can also send feedback. There's also a case study on COPD. So you can also go in through that one and do some additional CPD that way. And you can subscribe to get those case studies through the bulletins. So this is the relevant pathways all listed there for you on respiratory issues. And if you spend some time reviewing pathways, looking at management and then referral processes, you are able to also record the CPD time, and you can click on the CPD hours and it will take you through, next slide, Anne-Marie, I think, to how to record your CPD hours. So it's another way of, you know, just getting that time for the reading that you do, because I think lots of us, you know, think we have to do the sort of formal education sessions for our CPD, but there's lots of reading and, you know, things that we do through the day or in the evening when we're at home that is incidental CPD that you can record also. So next slide. So most of you have got access to Health Pathways, but if you haven't registered, because we now all have to have our own individual sign-in, you can send an email to the Health Pathways team, or you can scan the QR code there and register. So next slide. So I'd now like to introduce our speaker for this evening. Associate Professor Anne-Marie Southcott is a respiratory and sleep physician who took up her position as Head of Unit Respiratory and Sleep Disorders Medicine at Western Health in November 2009. Western Health provides respiratory and sleep medicine clinical services at several sites, including Footscray and Sunshine Hospitals and Melton Health. Dr. Southcott has a strong clinical interest in the broad range of respiratory illnesses and sleep disorders and in standards for pulmonary function and sleep laboratories. She's been involved in many clinical trials of asthma and COPD medications. Is currently a member of the TSANZ Laboratory Accreditation and Quality Committee, the NATA ASA Sleep Accreditation Sleep Advisory Committee, and the Statewide Equipment Program Domiciliary Oxygen Program Clinical Advisory Panel. She's also on the National Examining Panel for the RACP, Adult Medicine Specialist Physician Training Program. So thanks, Anne-Marie, and I'll hand over to you.
Okay, thanks, Jo. Just check you can hear me okay.
Yep, can hear you.
Great. Okay, so if I go too long, I'm sure I've asked Jo and Yvonne to tell me to stop. These are conditions close to my heart, and I'm happy to talk on them forever, but I'll try not to. So aiming to cover definitions, what are the main guidelines that we would have available to us, and look at some recent changes in approaches and new treatments, have a look at which COPD and asthma patients may benefit from specialist assessment, in particular how to assess disease control and identify patients at risk of deterioration and harm. And then we'll briefly cover important comorbidities. I'm not going to cover the general ones in any detail, but I will look at cardiovascular comorbidities in COPD. And I'll briefly touch on lung cancer with the advent of the National Lung Cancer Screening Program coming up shortly. I won't cover that program in any detail. I know that you've had some recent presentations through the Health Network, which are available, and then opportunity for questions at the end. So one of the problems, and with definitions, people can be lumpers or splitters and apply labels. So are these labels helpful or are they a hindrance? So splitters would have separate labels for asthma, COPD, and at one stage there was a proposed asthma and COPD overlap syndrome, which isn't really a syndrome, it's just features of different variations of the same disease. Lumpers, and there's quite a strong voice for this, would just say it's all airway disease with just different clinical and traits, some of which are identifiable and treatable. And these labels may influence our recognition of conditions and our treatment approaches, and that may be helpful or may be a hindrance. So if we go for the traditional definitions, chronic obstructive pulmonary disease is a group of disorders, and they are characterised by airway inflammation and airflow limitation that is not fully reversible. So if you look at the rectangle, that's the patients who have airflow obstruction on spirometry. Traditionally, the traditional model of COPD is it's a progressive condition associated with an abnormal inflammatory and repair response to noxious stimuli, and that may impact the small airways or it may affect the parenchyma, often both, but both of them through different mechanisms would cause airflow limitation. But there are a number of ways that you can develop fixed airflow limitation. So even though they may meet that spirometric definition of COPD, it may be because they've had long-standing asthma. Equally, patients who are certainly at risk of COPD with chronic bronchitis and ongoing smoking may not yet have developed airflow obstruction. And there's about 20% of patients with emphysema who have normal spirometry. So, the labels and relying just on one measure are still problematic. So as I said, COPD is defined by the presence of obstruction on spirometry. The most common cause is smoking related, with either loss of the alveolar walls in emphysema or chronic bronchitis, which is small airways related, but also long-standing asthma, bronchiectasis, and rare other systemic conditions and smoking-related conditions can cause it. Asthma definitions are also slightly murky, and they've been fluid over the years, and the key factor is the variability, and airflow obstruction is often reversible, either spontaneously or with treatment, so it's not always present, and that is sometimes a trap, is that, you know, the absence of bronchodilator reversibility on a lung function test doesn't rule out asthma, it just means that we've seen them on a good day. In some of the earlier definitions, they included this term airway hyperresponsiveness, which we can test in bronchoprovocation tests, but more recently that has come out of the definition, and it's really more focused on the symptoms, wheeze, shortness of breath, and chest tightness, which are variable over time and in intensity, together with variable airflow limitation. It may, though, be quite difficult to differentiate between patients with asthma with some irreversible airflow obstruction and some patients with chronic bronchitis and emphysema who can also demonstrate reversibility. So lung function alone isn't enough, and it's a clinical diagnosis. To try to differentiate it, COPD is generally progressive, tends to occur later in life, usually associated with a moderate smoking history, and the airflow limitation is not completely reversible. In contrast, asthma has a more variable course, tends to occur younger, but we all know of adult onset asthma. It's not associated with smoking history, but clearly many asthmatics can smoke. And the airflow limitation is substantially or completely reversible. And of course, patients may have both. They may have a background of asthma in childhood, they've taken up smoking or been exposed to other noxious stimuli and developed COPD in addition to their asthma. So I'll come back to this case later, but Mrs. DD, for differential diagnosis, is a 53-year-old woman who describes chest tightness and breathlessness on moderate exertion. She's comfortable with her activities of daily living. She's had a chronic productive cough for 8 years, and she's had winter bronchitis in the past 3. And this year she's had 2 attacks treated with antibiotics and bronchodilators. She's an ex-smoker with 30-pack year history, and this is her spirometry. You'll probably be seeing lung function tests from many different labs and different formats, and this is our previous format report. So we have expiratory flow volume curves, expiratory going up and inspiratory down. Blue is pre-bronchodilator, red is post-bronchodilator, and green is predicted normal. So on this, there is expiratory airflow limitation shown by that very typical concave shape to the curve. There is substantial reversibility of 41% improvement in FEV1 with an absolute change of about 700 mils. But if you look at her FEV1 FVC ratio, despite that reversibility, she remains obstructed. So we'll come back to this case later on, but this is to set the scene. So turning to the disease-specific guidelines that we work by, the Australian one is the Australian Asthma Handbook, and the international one, which they're aligned very closely, is the Global Initiative for Asthma, or GINA. And it shows a stepwise approach to management, and the difference between COPD and asthma is that because COPD tends to be progressive, you tend to be stepping up with the treatment all the time, whereas in asthma, hopefully you can achieve control and then may be able to step down treatment, and particularly if triggers have been identified and eliminated. This is the GINA representation of the stepwise approach to treatment. So step 1 is for mild intermittent symptoms. And the change in the international and local guidelines that came in a few years ago is to move away from as just relying on short-acting beta-agonist bronchodilators, but to move towards a combined anti-inflammatory reliever with inhaled steroids and a rapid onset long-acting beta-agonist. And the reason for that is that too much reliance on beta-agonists without steroids can actually worsen asthma tendency over time. And certainly long-acting beta-agonists should never be prescribed in the absence of inhaled steroids. That's been more of a problem in the United States, particularly with cost issues related to medications. As the symptoms become more frequent, then this is, and I'm only referring to adults tonight, you would usually start with low-dose inhaled steroids. Symptoms more persistent. The most common and preferred option would be combination low-dose inhaled steroids combined with a long-acting beta-agonist. With more persistent or severe, you can increase the inhaled steroid component, continue your LABA. Then you might think about leukotriene modifiers such as montelukast. Tend not to use theophylline very much. This is an international guideline, so the Americans are still a bit keen on theophylline. And then really when it's getting into the severe persistent asthma, then maybe be considering oral glucocorticoids or some of the newer biologic therapies. BT stands for bronchial thermoplasty, which came in, but I think it's now not available due to licensing of technology, but it may come back in the future. This is the Australian Asthma Handbook representation of the same thing. So the majority of patients could either be on low-dose combination ICS-LABA anti-inflammatory as a single inhaler therapy, or a regular maintenance low-dose inhaled steroid with a short-acting beta-agonist reliever as needed. Really very few patients, if any, should be on an unopposed SABA. Some patients who don't achieve control on the lower step may go up to a regular daily ICS-LABA combo. As you go up, you can increase the inhaled steroid strength. Then you might think about adding in a long-acting antimuscarinic bronchodilator approved for asthma, and particularly in the context of recurrent exacerbations or degree of fixed airflow limitation. And then really once you're getting to if you're not controlled at that level, that's probably the point where specialist referral may identify some other issues or some other treatment options. And then as they improve, then may be able to step down. There are a number of different treatment approaches. They all have their advantages and disadvantages. But the main theme behind this is that inhaled steroids are the cornerstone of asthma therapy. So you may choose anti-inflammatory reliever therapy as a single device and not on regular therapy. They may have a maintenance and reliever therapy, again, combined as a single inhaler. Might be able to do maintenance inhaled steroid and as needed short-acting beta-agonist, or a maintenance fixed-dose ICS-LABA combination and an as-needed short-acting beta-agonist. There's a sort of philosophical debate some years ago, and it's probably waned a little, is that if we're going for anti-inflammatory reliever therapy, are we accepting a degree of suboptimal control as opposed to sort of fixed dose high dose steroid combinations, which could achieve much better control, but at the expense of a much higher cumulative lifetime inhaled steroid dose. So really it's a discussion to have with the patient as to how fearful they are of inhaled steroids. Many of them are quite fearful. And then the device, the frequency, what's the preferred way that they would like to have the treatment. And in the Australian Asthma Handbook, there's a couple of quite good tables, which I think are in the slide pack that you'll receive, which I've hidden, just listing which ones are available for which approach according to the PBS. Whichever inhaler is selected, and these are some of the factors I mentioned, and I didn't cover environmental impact as well. The key part in the asthma in asthma management is this ongoing cycle of review, assessment and adjustment. And if you change the treatment, then review how it's going, reassess perhaps after an exacerbation again, have a further review. I think I may have taken it out, but the minimum frequency of review for asthma should be once annually, more frequently if they're pregnant or had an attack or change of treatment. The next concept is of asthma control compared to severity. Severity is confusing. Some people will immediately think of the severity of an asthma attack and whether it's life-threatening or not, or severity of asthma. So if somebody's been ended up in ICU a few times, then clearly they've got severe asthma. But a different way of defining severity is how much medication is needed to achieve good control and to maintain it. So if somebody's on continuous daily prednisolone to keep them good, then that's probably pretty severe asthma, even though they may be controlled. So when we're assessing control, we'd be looking at more of this chronic nature, and we'd define it by the frequency of symptoms over the past 4 weeks. If you ask a patient what their asthma control is like, they'll tend to think it's much better controlled than we would, and they'll often say, "Oh, it's great. The blue puffer works really well," but that's really not what we're trying to get at. I would then show them a slide like this as to what do I mean by asthma control. So good control is fewer than 2 or fewer daytime symptoms per week, no limitation of activity, no nighttime waking, not needing rescue treatment or less than twice a week, normal lung function and no attacks. Uncontrolled is 3 or more of these in any week, and obviously there's partially controlled in between. So when the patients see this, oh, maybe I'm not quite as good as I thought I was. There are ways that we would put numbers to this. So the questionnaire that most respiratory physicians would use routinely is the Asthma Control Questionnaire, or ACQ, and that is 5 questions on symptoms, covering the table I just showed you, and it puts a numeric version to that. You can have a 6 and 7 item version, which include spirometry and beta agonist use. Whatever the number of questions you have, you total up the answers and divide by the number of questions. So, for example, waking by asthma several times a night gets you 3, moderate symptoms first thing in the morning 3, moderate limitation of activities 3, shortness of breath 3, and wheezing a moderate amount of the time would get you a total of 15 divided by the 5 questions, so you get an ACQ of 3. And this is an internationally standardised questionnaire. It's available in different languages. It's copyrighted by the creator, Elizabeth Juniper. And if your score is 0.75 or less, so you're generally between nothing at all or hardly ever, then that's good control. Not well controlled is more than 1.5, and partial control is in between. So we would use this quite a lot on visit to visit. It's also one of the criteria for getting access to biologic therapy for patients. So they would need a score of 2 or more to be able to access biologics, as well as a whole number of other criteria. There are other questionnaires. Asthma control test, I think, has been promoted by some of the pharmaceutical questions. It has 5 questions relating to control over the previous 4 weeks. In contrast with this one, the higher the score is better, and a score of 19 or less is not well controlled. But I mean, I must admit I haven't used the asthma control test for years. If you have a patient who you've then identified has poor symptom control, well, what do we do? And I think it's very, we've obviously got all these new exciting treatments and it's great, but it's the importance of the basics are really important. So you need to assess that the patients are actually using their inhaler properly, both in a technique and also adherence to therapy. And obviously ask about adherence to therapy in an empathetic sort of way. It's common to miss doses. How often would you miss it? Do you tend to remember to take it more at night time or in the morning? Sometimes it's about the cost of treatment, beliefs about medications and side effects. Then it's always, well, is the diagnosis actually asthma? Might it be cardiac failure? Might it be something much more rare, such as an upper airway stenosis or tumour or things like that? If it is asthma, are there other issues that are contributing to it? If they just bought a kitten that's sleeping on their pillow? Are there other comorbidities that may be impacting, such as sleep apnea or bronchiectasis or things like that? Once you've sort of sorted that out, then you would consider stepping up their treatment to the next level. If you've really gone up to quite high inhaled steroid content combination drug, or if there's ongoing concerns, or if it's very severe and hard to control, or if it's occupational asthma, which we know has a poorer outcome, then they should be some of the triggers for the specialist referral. In terms of adjusting the therapy, so stepping down, if review control periodically as a minimum annually, perhaps up to, it's recommended for weekly during pregnancy. If good control is maintained for approximately 3 months and the patient seems to be at low risk of attacks, then you could consider stepping down dropping down by 1 step. The baseline treatment, though, should always be either a low-dose inhaled steroid or a PRN low-dose anti-inflammatory reliever. If you're stepping down, you should update the written action plan, and you shouldn't try to step down if the patient's about to be travelling or if they're pregnant or if they're exposed to triggers. So if somebody with a history of thunderstorm asthma, you probably wouldn't want to step them down in September. You might think about it a different time of the year. In terms of stepping up treatment, as mentioned, you'd consider their level of control, their adherence to therapy, the risk of attacks, and alternative explanation for their symptoms. High-dose inhaled steroids were used very widely in the 90s and early 2000s, but it becomes a sort of a plateau effect where they don't seem to respond much and they tend to get more side effects. So high-dose inhaled steroids really should only be short-term, and if they're needing ongoing high-dose inhaled steroid or frequent courses of oral steroids, then that's another trigger for specialist referral. This is an Australian version of a similar sort of approach to step up and step down. So going up from ICS alone to ICS LABA, potentially increasing the ICS LABA combination content. If they're well controlled, then you could stay on an ICS LABA but drop down the ICS content. If it's still well controlled, you could consider either ceasing the LABA and going back just to an ICS, or going to an ICS LABA pairing approach. In terms of risks of deterioration, patients who are at risk of asthma exacerbations are those who have poor control. They've had a history of an exacerbation in the previous year using large amounts of short-acting beta agonists. Those who have poor lung function and have a poor perception and/or have a poor perception of either their symptoms or their lung function. Other lung diseases present as well. Patients with mental health challenges, socioeconomic factors increase the risk of exacerbations and other exposures. And those who have been shown to have measures that would suggest persistent eosinophilic airway inflammation are more at risk of attacks. And it's was initially shown on sputum eosinophils. That's quite challenging to do, and we use blood eosinophil count as a surrogate marker associated with the degree of eosinophilic airway inflammation. For those at risk of life-threatening asthma, so factors above the first lot, previous episodes of life-threatening asthma, sudden onset, so what we'd think of as brittle asthma, patients who tend to delay presentation, those who have no written action plan, or comorbid cardiovascular disease. Next one to think of is thunderstorm asthma. So do they have hay fever in the spring? I think there was a campaign from Wagga after one of their thunderstorm asthma outbreaks, sort of, if you sneeze and wheeze, you're probably at risk of thunderstorm asthma. Then there are other factors that are associated with accelerated loss of lung function, and they include those with chronic mucus hypersecretion, history of asthma attacks, cigarette smoking, and occupational asthma. And then lastly, the other risks that we often expose patients to are the risks of the treatment that we give them. So there's an increasing recognition of the dangers of oral corticosteroids, and a position paper came out from the Thoracic Society of Australia and New Zealand a few years ago now. And obviously oral steroids have an excellent benefit in acute exacerbations and in chronic severe asthma, but they're associated with potentially severe adverse effects both acutely and in the long term, which can cause a significant impact on the patient's quality of life. Prescription of oral steroids for asthma is common, and respiratory physicians are probably some of the highest prescribing groups of steroid prescribers in the country. And there is increasing and strong evidence for the overuse of steroids and the harmful doses, and certainly a lifetime dose of 1,000 milligrams of prednisolone is associated with risk and harm, and even it's been reported that 500 milligrams over a lifetime might be harmful. And that's not a standard sort of course for asthma, would be about 150 to 200 milligrams. So it doesn't take many courses of steroids to get into that harm territory. How might we try to reduce the burden of oral steroids? Is to try to improve our basics treatment. Is the diagnosis confirmed? Is it severe? Have we optimized their inhaler therapy? Looked at all their trigger factors, managed comorbidities, looked at the social environmental factors, and also optimized patient self-management skills in terms of treating exacerbations early, potentially with inhaler. And then if that's still not right, then looking at other treatment options. So we might be looking at suitability for biologics. There's also evidence for macrolide therapy. And then if absolutely essential, then find the lowest possible dose of oral steroids. But I think wouldn't say it's a treatment failure, but it means that we're really quite struggling to get on top of it. So in terms of, I've mentioned this already, but specialist referral would be if there's doubt about the diagnosis, if there's assistance required in management of comorbidities, and really about are they patients suitable for advanced treatments if they're not able to achieve asthma control on fairly standard treatment, which is the minority of patients, but certainly these new treatments can be life-changing. And I think that's one of the very exciting things about asthma that's, I've seen during my career. So asthma was considered as a single disease in the 1900s. The heterogeneity became sort of recognised in the 40s, and it was only in the 80s that inhaled steroids came in, long-acting beta agonists and leukotriene modifiers. As I said before, we tended to perhaps overdo the inhaled steroid dose, particularly commonly in Australia, New Zealand, and perhaps England, not so much as USA. Inhaled combination ICS LABAs came in the sort of early 2000s or late 90s. And then in the United States, there was a large research program called the Severe Asthma Research Program, trying to identify clusters and phenotypic factors for patients with asthma that may help to understand some of the mechanisms and identify potential treatments. Long-acting antimuscarinics started to come into use about the same time. And then from the sort of 2000 onwards, with better understanding of these mechanisms towards the different asthma phenotypes, we now have a suite of biologic therapies available. Not all of them are available in Australia, so Referral is not available in Australia. Tezepelumab is now licensed on the TGA, but it's not yet available in Australia. But I'll touch on that briefly. So this is what I mean by asthma phenotypes. So we might have early onset asthma in childhood, late onset, often, the nasal polyps, aspirin sensitivity group. Are they have chronic symptoms? Do they tend to have exacerbations? Do they have lung function limitation? Is there presence of inflammation present either in blood or biopsies or exhaled nitric oxide? And then this sort of puts them into these clusters. So Th2 is the sort of T helper type 2 inflammation, and these are the patients that may respond to some of the, particularly to steroids, anti-inflammatory treatments. Whereas the patients who don't have the Th2 phenotype would tend to if they're not controlled, we're pushing the steroids higher and higher, well, we're treating the wrong disease and we're giving them side effects of the steroids, particularly, for example, obesity-associated asthma without inflammation. So I was trying to understand what's underlying it all to help guide us with treatment, and then use biomarkers to help identify these groups. So currently we have biologics that can target the allergic pathway through IgE. So that's omalizumab. Eosinophilic pathways, so that's mepolizumab and benralizumab. IL-4 and IL-13, looking at the Th2 cells, that's dupilumab. Tezepelumab, which is the thymic stromal lymphopoietin factor, is up here in dendritic cells and epithelium, and there'll be more to come. Also down here, we've got leukotriene receptor antagonists and modulators. Later, there'll be other treatments looking at smooth muscle, that sort of thing. So it's trying to understand the underlying pathways, then helps to develop treatments. With these different treatments, there are biomarkers that we can use to assess the patient, to find the patients who are likely to respond to them. So a blood eosinophil count is one of the markers for response in terms of reduction of exacerbations. eosinophils may be raised in both allergic mechanisms and also non-allergic mechanisms. So it's not clearly identifying patients suitable for IgE therapy or IL-5 based therapies. Exhaled nitric oxide has been associated with the response to dupilumab for anti-IL-4, IL-13, and also responses to omalizumab. And the sort of benefits that we would expect would be reduction in exacerbations of approximately 50%, a significant reduction in the oral steroid use, and improvements in quality of life, and degree of lung function impairment. There may be beneficial effects on other comorbidities, such as chronic rhinosinusitis with nasal polyposis, atopic dermatitis. So, for example, dupilumab is also used for eczema. Chronic urticaria omalizumab is used for that, and EGPA, formerly known as Sjögren-Strauss syndrome. There's also evidence for mepolizumab and benralizumab for that. There's also practical considerations in terms of the dosing, the number of injections, and the frequency. And so we would, when we're assessing the patients, we would try to make a choice as to which is the best of the options for this particular patient, because often they may be eligible for more than one treatment. So just to sort of go through a couple of cases. This was one of our earlier patients, Francisco. We saw him first back in 2015, and at that stage he was 47. He had asthma since childhood, needing 2 or 3 courses of steroids a year. So if you sort of think 30 plus years of steroids, that's quite a steroid burden. He was a never smoker. His triggers were cold infections and exercise. He didn't have any inhalational exposures. He had a background of allergic rhinitis. And he was uncontrolled on seretide, inhaled nasal steroids. He'd tried montelukast in the past and found it ineffective. And his lung function was pretty ordinary. FEV1 50% predicted, with some bronchodilator response, but with persistent airflow limitation with an FEV1 FVC ratio of 53%, and it's a large bronchodilator response. So he does have fixed airflow limitation on his lung function tests. I don't think most of us probably wouldn't call him COPD. Asthma patients who've never smoked tend to get a bit offended if they're told that they've got COPD. So we probably wouldn't call him that, and that's why labels may or may not be helpful. We'd tried pushing up his inhaled steroid dose. That hadn't really worked. We'd tried Tylade when it was available. Didn't really do much. It came back. Lung function was still pretty awful, still with ongoing bronchodilator reversibility. His control was poor, with an asthma control questionnaire of 3. So some of the things we'd thought about were, could we do anything to improve his allergic rhinitis? He didn't have any polyps. How might we approach him with investigations? So we wondered about ryegrass desensitization. We were told we couldn't do that because his asthma control was too poor and his lung function was too bad. There wasn't anything really targetable in his nose. On his blood tests, he had a moderate elevation of his IgE. His eosinophil counts ranged from 0 to 0.3 to 1.0, and that's one of the traps, and sometimes we may need to repeat the eosinophil count repeatedly because they, on steroids, they go to 0. So you may need 2 or 3 times to try to get an eosinophil count, and may give patients a few blood forms to say, do it before you start the prednisone. He also had RAS test positivity for grass allergy and house dust mite. So by this stage, we were tried most things. We put him into a research study we were doing at the time with a leukotriene pathway medication, but he didn't respond. Whether he either didn't respond or he got placebo, I don't know, but we withdrew him from the trial. We wondered about anti-IgE therapy to target his allergic asthma, but at that time, Benralizumab was just being released, and so we enrolled him in a patient familiarisation program, with the option to switch to a different biologic if he didn't respond. And it's been wonderful for him. His asthma control questionnaire went from 3 to 0.4. His nose improved. He hasn't needed any oral steroids for 5 years. His lung function has improved somewhat. It's still not normal, so it went from about 1.7 up to 2.5. It's drifted back a bit. And so he really is the ideal patient. And I think most of us would not have too much difficulty in identifying him as somebody who needs referral for consideration of advanced treatment. So the points with him, as said, the eosinophil count may vary, will vary according to prednisolone dose. He had a number of options for his biologic therapy, or he would do now. So if we saw him now, he'd be eligible for omalizumab, mepolizumab, benralizumab, and dupilumab. We tend not to start up front with dupilumab because there is an association with a flare of eosinophils. So we tend to use the others first and then switch if need be, unless the patient has severe atopic dermatitis. Obviously, you need to deal with any comorbidities as they arise. And then the other thing that happens is the patients feel so good, well, they tend to stop using their inhalers. We still say it's very important for them to be using a regular inhaled steroid as the cornerstone of asthma treatment, and would encourage them very strongly to continue, but often we will wind back the dose. If people have been on montelukast, we'll tend to stop that, and we'll just sort of wind it back a bit, but never stop them completely, or never advise them to stop them completely anyway. As we've become more experienced and confident in the use of biologics, I think we're now starting to think of a little bit more outside the square. So this is a more recent case, Mary. She's an 81-year-old lady who is now living in a residential aged care facility, but at the time was not. She'd been diagnosed with Alzheimer's dementia with behavioural problems associated with dementia. And in first half of 2023, she'd had 10 admissions with recurrent exacerbations of asthma, and these were associated with delirium, aggression, agitation, which was worsened by oral steroids used to treat her asthma. There were probably some adherence issues with her inhaler therapy, and at that stage she was living at home, and her daughter was struggling to help care for her. And on her blood test, she had really persistently high eosinophil counts. This is just one snapshot of a week or so, but this had been across the board over some time. So I said she's not your typical asthma patient, but everybody was really struggling with her. In terms of her family, she was having a miserable time herself, coming in and out of hospital all the time. So we thought, well, really, should we try a biologic to see if that can help her? So we decided to try her on Benralizumab. And the reason that we chose Benralizumab was that she had persistent eosinophils with frequent exacerbations. That was the lowest injection burden in terms of frequency of dosing. The logistics of it were challenging. So we applied and we started it in hospital. We had to, she was then eventually moved to a residential aged care facility, so I had to train the staff. We used there are some specialist pharmacy support programs to help with this. There's also nursing support through some of the companies. Her daughter was very helpful in terms of bringing in medication for us to use in hospital, and our asthma outreach nurse really put it all together and got it all to work. And it's been great. Her asthma control has improved markedly. If you ask the nursing home staff, they would estimate her ACQ as 0. She's not had any attacks. She's not had any admissions to hospital. Although I think that's not just because of Benralizumab, it's also because she's in a supportive environment. She's probably is more adherent to her inhaler therapy as well. But I think it really did make quite a big difference. So I said, it's not probably quite your typical asthma patient that you'd be thinking about for these treatments. So as I said before, referral for specialist would be confirmation of diagnosis, management, comorbidities, and consideration of advanced therapies. So if there's any burning questions, we can take them in the chat now, or otherwise I'll push on.
Nothing's come through yet, Sue. Anne-Marie, but just a reminder to people, I can see some people who are here have got sort of funny names and iPhones and things. I'm sure that's not your real name. So if you could just go into the chat and type and let Yvonne know who you really are, that would be helpful. Thanks. Over to you, Anne-Marie.
Thanks. Okay, so I'm now going to move on to COPD. So similarly, we'd have Australian guidelines, so it's the COPDX plan, and the global international strategy rather than a guideline is called GOLD, the Global Initiative for Obstructive Lung Disease. So COPDX stands for Confirmed Diagnosis, Optimise Lung Function, Prevent Deterioration, Develop Support Network and Self-Management Plan, and Manage Exacerbations appropriately. It's evidence-based. It's updated twice a year, and available through the Lung Foundation. So as I mentioned at the start, COPD is associated with noxious stimuli inhaled, and patients who are susceptible to the effects of smoke. There's a small proportion of people who are regular smokers who don't seem susceptible. Patients always quote them to us. But the majority of smokers who are susceptible will have an accelerated loss of lung function. And the good news is to try to identify them earlier, help them stop smoking, and that will slow down the rate of loss of lung function. That's the traditional Fletcher-Peto curve. The reality is probably slightly different, so that patients will tend to lose lung function faster earlier. And so it really highlights the need to try to identify smokers and intervene earlier rather than later. In terms of the etiology and taxonomy of COPD, this is some of the GOLD slides. The commonest group is patients with environmental COPD, mostly related to cigarette smoke in our situation, but certainly cannabis is definitely associated with bullous lung disease. Vaping and e-cigarettes haven't been around as long. We certainly know of toxic effects from them, but they've not been, I think, as clearly associated with longer-term damage just from a time effect. A number of our immigrant populations are exposed to biomass and pollution for indoor cooking. Other causes would be related to genetically determined COPD with alpha-1 antitrypsin deficiency, impacts of childhood infections, and sort of combined COPD and asthma. So there's lots of different ways that you can get to COPD, and this is also including small lungs, prematurity, growth failure, and then different rates of decline. So you may end up with normal, supranormal, or below normal lung function. This is the Lung Foundation Australia COPDX stepwise management of stable COPD graph. As I said at the beginning, similar to asthma in that you increase the treatments as patients get worse, tend not to step them down though. How this has changed over the years is that the role of inhaled steroids is tending to come in a little bit earlier now. Initially, it was thought to be really severe disease or very frequent exacerbations, with more and more studies using triple combination therapy, probably better idea of which patients are suited to in the use of ICS. At any level of COPD, the key factor is smoking cessation, preventing deterioration, so immunisation, optimised function, pulmonary rehabilitation can be applied at any stage of the COPD pathway. And then other non-pharmacologic treatments would tend to be as the illness progresses, so advanced care planning considerations, thoughts about transplantation suitability, oxygen assessment, that sort of thing. So that's all the sort of the non-pharma type interventions. And then in terms of the pharmaceutical interventions, tend to start with short-acting bronchodilators, usually a SABA. I tend not to use Atrovent or short-acting antimuscarinic antagonists, mainly because it tastes so terrible. As symptoms are more persistent, we tend to add in a long-acting bronchodilator. That can either be a LAMA or a LABA. It doesn't really matter. If the breathlessness persists with one, then you can go for a combination LAMA-LABA, and then you'd start to think about which patients are suitable for inhaled steroid. And as with the asthmatics, optimise and inhaler technique at each visit. Combination puffers are probably better than multiple ones, just to try and reduce confusion and cost. They're the main sort of points of that. In the gold strategy, the treatment goals are defined as reducing symptoms and reducing risk. So in terms of disease progression, treating exacerbations, reducing mortality. In terms of reducing symptoms, the way we would measure symptoms in COPD would either use the modified Medical Research Council dyspnea scale. I think that's probably the one that most respiratory physicians would use. It's the simplest. The COPD assessment test, or CAT, that again has been promoted by some pharmaceutical companies. It's a bit more complicated. And the St. George Respiratory Questionnaire is well validated, but quite long and typically used for research studies. But you may see some of the mentioned in publications. This is the modified MRC scale. So grade 0, only breathless with strenuous exercise, through to grade 4, too breathless to leave the house, or breathless undressing and dressing. Why it's called the modified MRC was that they've shifted the levels up. It used to be the original one was 1 to 5, now it's 0 to 4. Same questions. This is the CAT. It combines additional symptoms, so it does include breathlessness, but it's also chest tightness, phlegm, cough, confidence, sleep, and energy. So it's a bit more of a global tool rather than just COPD. It's a generalised quality of life score. So looking at the GOLD assessment pathway for control, the three sort of aspects that we'd think about would be how bad is their lung function, so it's the severity on spirometry, how frequently they're exacerbating, and then how breathless are they. So that's in this sort of A, B, and E. So A is not very breathless or symptomatic, B is quite symptomatic, and E is exacerbations. And there's often quite a discrepancy between spirometry and the degree of symptomatology. This has morphed over the years as well. They had no grid, then they had an ABCD. Now they've gone to ABE, and I think ABE is probably more sensible in terms of the factors that we're trying to consider when we're making treatment decisions. So this is the initial pharmacotherapy approach suggested by Gold. So if they're not particularly breathless in group A, you'd think of a bronchodilator. If they're more breathless, you'd possibly be leaning towards a combination bronchodilator, but often we would go with one and then add in a second one if they remain breathless. And then if they're having exacerbations, then we would start to think about inhaled steroids. So the studies have shown benefits if they've had one severe exacerbation leading to hospitalisation or two moderate exacerbations requiring additional treatment, and particularly if there's any sort of eosinophil signal, definitely above 300, but down as low as 100 has been associated with benefit of inhaled steroids to reduce exacerbations. And this is that can be repeated at any time, and often sort of we look back historically, and we'd also use the eosinophil count to sort of consider whether if we're considering withdrawing inhaled steroids, that we'd be, I think, reluctant to if there was an ongoing eosinophil signal. Then this is the Gold sort of follow-up pathway, looking at some of the other treatment options. So if they're still symptomatic despite triple therapy, then if you're in the United States or Europe, you might have access to roflumilast. Theophylline is the sort of the poor, the poor person's version of that. So with chronic bronchitis, recurrent exacerbations, there's some benefit, also significant GI side effects. Macrolides, particularly if there's recurrent exacerbations, chronic bronchitis may be helpful. And there's now increasing evidence of some of these biologics, which have emerged through the asthma pathways, being applied to patients with COPD. The first one that was studied was dupilumab, and that has recently been approved through the TGA for COPD. With eosinophil signal and poor control. It's not yet available on the PBS, and I don't think we'd say it's mainstream therapy yet. And hot off the press, mepolizumab, targeting the eosinophil pathway, has just been approved by the FDA in America. It's not yet TGA approved in Australia. But as I said, neither on PBS at this time. But that's sort of where it's heading, and this is sort of a little bit about what I was talking about was, these treatable traits, is it COPD, is it asthma, some of the treatments are coming together. So this is sort of a stop sign, a stoplight system for consideration of inhaled steroids. So in some of the big triple therapy studies, which have shown reduced mortality related to COPD, as well as reducing exacerbations and improving symptoms, there was only about 11% of patients in the sort of moderate to severe COPD group with recurrent exacerbations that fitted into this sort of didn't benefit from steroids, and they were ones with eosinophils less than 100. We'd certainly be concerned about adding too much inhaled steroid if there's history of TB or recurrent pneumonia as one of the potential side effects of inhaled steroids. Sort of patients that we would like to see, again, if there's diagnostic uncertainty, unusual symptoms of concern such as hemoptysis, if there's really a very rapid decline, if they're developing right heart failure related to their lung disease, whether we need to be considered for oxygen therapy, then sort of are they suitable for surgical type treatments, either bulectomy if it's compressing the lungs, lung transplant or lung volume reduction, accessing pulmonary rehabilitation, early onset, could they have genetic modified COPD such as alpha-1 antitrypsin, are they having frequent infections, should we be looking for comorbid bronchiectasis, are they suitable for macrolide therapies, and then other comorbidities such as breathing pattern disorders, which probably a bit more common in asthma than in COPD. So, excuse me, coming back to our case, Mrs. DD, so we're trying to sort of apply guideline-directed care to her. So just to recap, she has symptoms of chest tightness and breathlessness on moderate exertion, winter bronchitis, at least 2 attacks this year already. She's an ex-smoker, having stopped 3 years ago with a cumulative smoking history of 30-pack years. This is her spirometry, and it actually looks quite like Francisco's, but and that's the problem of overlap. So again, she has an obstructive pattern spirometry. There is significant reversibility, but she has persistent airflow limitation with an FEV1 FVC ratio of 60% close to bronchial. So she doesn't come up to normal. So if it completely reverses, then it's definitely not COPD. But this is where she's at. So the question really at this stage is, what is the diagnosis? What sort of treatment should we give her? And what do the guidelines say? And then which guidelines should we be using? So because of the webinar format, I'll ask the questions for you. So what other questions do we have? Yes, she had a history of childhood asthma. She was wheezy. She does have hay fever. She sneezes with cats as well. Her chronic bronchitis probably started 8 years ago at the age of 45. So that's that sort of cutoff about when the symptoms start. As before, she's had winter exacerbations. She's breathless on moderate exertion, and she has symptoms every day. So we're getting a little bit of additional flavour for her. So if we try to put her into one of our guidelines, if we think she's got COPD with some reversibility, she's from a lung function point of view, COPD, she's probably in the mild range. But she does have recurrent chest infection. She's breathless on exertion. So are we treating her as mild COPD with some bronchodilators? Although we might now be thinking more about inhaled steroids because she's had recurrent exacerbations. Or if we're thinking about asthma, based on her childhood history, we'd be thinking, well, has she got moderate persistent asthma with persistent symptoms and poor lung function? And we might be thinking more about combination LABA inhaled steroid sort of treatment. So there's a bit of, this is where trying to apply a label for a patient can come unstuck if we choose the wrong one. And this is where the sort of the treatable traits approach comes in. So throw out COPD, throw out asthma, and just call it airways disease, and then we look for what are their symptoms, what are their spirometry, what are their biomarkers such as the eosinophil count, how many exacerbations they had, smoking history, that sort of thing, and then can we sort of target the different factors. So treatable traits has been shown to work in COPD and in asthma. It's about trying to establish a diagnosis, looking at future risk, comorbidities, exposures, looking at biomarkers. So as I mentioned before, there's now evidence for dupilumab therapy in COPD with recurrent exacerbators with eosinophil count. So this is where potentially over time the guidelines may end up with just one guideline for asthma, for airways disease rather than separate guidelines, but time will tell. So this is her again. So probably thinking that she's either long-standing asthma who has smoked with fixed airflow limitation, or she has both asthma and COPD. And I don't think we'd be wrong with either of those. As I said before, at one stage there was a fad to call it asthma combined COPD syndrome, ACOS, or one of my colleagues used to call it chaos. That I think is just really recognising the different phenotypic characters of this patient. So this is how I sort of think about inhaler treatment. So obviously you take the history, we'd look at the age of onset, variability of symptoms, what their lung function is like. We'd look at some of the biomarkers, think about bronchoprovocation testing if we're not sure about diagnosis of asthma, potentially do a CT scan of the chest if they've got recurrent infections, looking for any sort of structural lung disease, quantifying degree of emphysema, etc. So if we are thinking it's predominantly asthma, then the starting point is always inhaled steroids, and you'd consider adding an ALABA, and then later on adding an ALAMA if there's severe persistent symptoms or recurrent exacerbations. Then, as we said before, thinking about the treatment approach, fixed dosing, single inhaler therapy, maintenance reliever therapy, etc. In contrast, thinking of COPD, then you'd start off with short-acting beta agonists, probably then add a long-acting antimuscarinic bronchodilator. If they're persistently breathless, add in a ALABA as well. And if they've had recurrent exacerbations or they've got low lung function or there's an eosinophil signal, then you'd add inhaled steroid. In the middle, if it's asthma COPD combined, then rather than following the asthma pathway of just, ICS alone isn't enough because they've got fixed airflow limitation, they've got symptoms. So starting with an ICS LABA for for COPD, I think is very reasonable. And then you can add in a LAMA for either history of exacerbations or fixed airflow limitation. And at all steps along the way to think about, inhaler technique, patient preference, what we're allowed to do according to the PBS, and reviewing adherence and symptom control. So the sort of themes underlying that are inhaled steroids are the mainstay of asthma therapy. Bronchodilators are used for airflow limitation and symptoms, and we should be trying to avoid unnecessary inhaled steroids in COPD, although that group is now sort of shrinking. So in terms of starting therapy, asthma would be ICS or anti-inflammatory reliever. Asthma COPD combined, we'd start with an ICS LABA, and this is mainly driven by what's available through the PBS and convenient for the patient. If it's COPD, then I'd probably start with SABA, go to a LAMA, still breathless, go to LABA-LAMA combo, and then if they've had exacerbations, then I'd go for triple therapy. So for this particular patient, I'd probably start in the middle with the ICS LABA combo. I've ruled out option A for asthma. Single inhaled steroids isn't going to be sufficient. I think we are, for COPD, we are quite justified in going to an ICS LABA combination, and I think she really needs the ICS because of that his background of asthma, rather than going for the bronchodilator pathway alone. So this is where I'd go for her because of that background history of asthma, the ongoing allergic phenotype with the cats and the hay fever and stuff like that. So that's sort of how I'd approach it in practice. Right. Next part is about comorbidities in COPD. So the vast majority of patients with COPD have at least one comorbid condition, so over 85%. And the comorbidities are responsible for approximately 1/3 of deaths in COPD. Cardiovascular disease is responsible for over half of the hospitalizations and deaths in COPD patients. They have shared pathophysical mechanisms, and the impact of treatment may influence features of the other condition. So I'm just going to sort of look at that in a little bit more detail. So this is a graphic representation of a comorbidome. So this was a prospective study of over 1,500 patients with COPD. And the size of the circles represents the prevalence of the condition. Sorry, I was waiting for the Met Call announcement to go. So very high prevalence of hypertension, over 50%, dyslipidemia, coronary artery disease, strokes, heart failure, atrial fibrillation. So very, very frequent cardiovascular comorbidities. In terms of causes of death in COPD, this is quite an old study, 20 years old now. So in terms of causes of death of COPD, about a third are lung cancer, 22% of them are cardiovascular. So this was in patients with mild to moderate airflow limitation. So that's why probably the respiratory causes of death are relatively low. Looking at another study called TORCH, which was looking at combination ICS-LABA treatment in COPD. This was a more severe group with FEV1 below 60%. And in terms of the adjudicated deaths in that trial, about a third of them were respiratory, 26% cardiovascular, and 21% cancer. So a lot of non-respiratory deaths in this group. So that's why it's really important to consider presence of cardiovascular disease in COPD. Obviously, they have shared risk factors, smoking, aging, lipids, hypertension, etc. COPD is an inflammatory condition with repeated oxidative stress, and that can worsen cardiovascular. There's mechanical effects of lung hyperinflation on the heart, so a lot of shared risk factors. There's also a degree of symptom overlap. So if somebody's presenting with worsening breathlessness, should we just say, oh, it must be their COPD, or should we be considering more about the development of cardiac failure? We also know that acute exacerbations of COPD are very pro-inflammatory, and there's an excess of cardiovascular events following a acute exacerbation. So these are the sequential time points, 1 to 10 days. 0 is during admission, 1 to 10 days, through to more than 160 days. And this is patients experiencing a cardiovascular event. So quite high. This is all common exacerbations. This is severe exacerbations. So quite high risks of cardiac events, 40-fold in increased risk of death during a severe exacerbation of COPD. And then that rate of excess cardiovascular events take quite a while to settle. So it's a pro-inflammatory situation. Patients with COPD are between 2 and 5 times more likely to develop cardiovascular disease. They have a higher prevalence of cardiac failure, heart failure than the general population. They have higher rates of admissions for heart failure. The prevalence of heart failure is approximately 30% of patients hospitalised with acute exacerbations of COPD. The presence of heart failure worsens the prognosis of COPD and vice versa. And COPD is also very common in heart failure patients, up to about 40%. Similarly, coronary artery disease is more prevalent. It's present in about 22% of patients admitted with acute exacerbations of COPD, increased rates of acute MI, hospitalisation, and worse outcomes. So we need to be thinking about cardiovascular disease. Often we're getting CT chests on these patients and just seeing some calcium around the coronary arteries is a significant flag that at increased cardiovascular risk. In terms of arrhythmias, COPD can increase the rate of atrial arrhythmias. So atrial fibrillation is present in up to 30% of patients with severe COPD. In terms of the effects of therapy, we should be cautious about using extremely high doses of bronchodilators. There was some early concern about long-acting antimuscarinic bronchodilators, but in the standard doses of long-acting bronchodilators, the studies have shown safety. So we would recommend them at the recommended doses, but not going too much overboard. As shown in that comorbidome slide, hypertension is probably the most frequent comorbidity. Pulmonary hypertension may be caused by COPD in terms of cor pulmonale, and certainly in the presence of pulmonary hypertension, the prognosis for COPD is much worse. In terms of therapies that we might be thinking about for these patients, cardioselective beta blockers are safe, so they shouldn't be withheld from COPD patients with heart failure. It's been shown that ACE inhibitors and angiotensin renin blockade may reduce exacerbations. Diuretics can help in terms of the right heart failure related to COPD. Antiplatelet therapy has been shown to reduce exacerbations and mortality and improve quality of life. Statins are beneficial in COPD patients if they have a proper indication for a statin, so not to be used more broadly, but they may also reduce the risk of developing pulmonary hypertension. So in terms of cardiovascular disease and COPD, they have complex mechanistic interrelationships. COPD increases the risk of having CVD. Both of them together worsen the prognosis of each condition, and we need to optimise the diagnosis and treatment of both. And what I think the respiratory specialists would recognise is that we're not very good at that, and the GPs are really much better at assessing cardiovascular risk and dealing with it. And this should be routine in all COPD patients. But equally, if somebody has worsening dyspnea, we should be thinking about non-COPD causes of that and dealing with them. So, you know, anemia, thyroid function, but particularly heart failure. And finally, turning to lung cancer. So again, as you saw on that slide of the deaths in some of those COPD studies, lung cancer is common in COPD patients. So increased rates of lung cancer in older patients, greater smoking history, if emphysema is present, if they've got airflow limitation, if they've got a family history of lung cancer and low body mass. So certainly if patients are being screened for lung cancer, it's an opportunity to think about their COPD, but also conversely, if somebody with COPD who potentially may not fit into the screening guidelines due to age, for example, it's maybe worth considering whether you want to do some imaging. As I said at the start, I'm not going to talk specifically about
5 minutes. Your cooperation in the more area this time would be appreciated.
I'm not going to talk about the lung cancer screening program. There are some resources which have been sent. In terms of the referral pathways to Western Health, obviously if patients are symptomatic, hemoptysis, etc., that you're thinking may have lung cancer, that's not a screening pathway. They should be evaluated for suspected lung cancer and referred as query lung cancer. Obviously, there's a separate program for the screening program for the asymptomatic patients, and the algorithms of the screening pathway will advise in terms of follow-up versus referral. And for the patients that have an increasing size or very suspicious opacity, then they would be referred into our query lung cancer clinic. There may be other incidental findings identified in the screening program, for such as interstitial lung abnormalities, so they can be referred through our general respiratory clinics for assessment. And then obviously already we're people are identifying many nodules because they're having CTs for other reasons, and they will be assessed and triaged according to need. And I guess I would sort of, as we all learned through the lung cancer screening program, people will be a bit more confident in terms of nodule advice, and particularly if the numbers are very large, we may, not necessarily push back, but just sort of return back with some advice as to this is what we recommend. Rather, if we find that we're struggling with capacity, obviously we hope we can build our resources, but that's the current situation. So to wrap up, so we've just had a look at the asthma and COPD guidelines that are in use. And underpinning those are the recognition of many of the mechanisms and associated therapies. We've got a wide choice of therapies, and it's trying to apply them to the individual patient, consideration of the risk of the disease and the risk of the therapies, and refer on for refractory and or severe disease, and to certainly think about managing the comorbidities. So I think that's it. So I'll open it up to any questions, and I think you have 4 minutes.
Now, has anybody got any questions they would like to ask Anne-Marie? Haven't got anything because I think it has been such a detailed presentation. So really, Anne-Marie, it was fantastic run through of COPD and asthma, and a real update on therapies and the challenges of the patients who fit in both camps, or straddle lots of different things. And like we know, they're never just got a single disease. There's lots of things going on. So that the challenges of the patients that come through our doors and the need to kind of filter them out as we go along. So, and I think, the patients, I think that for me, the challenges I've had are the patients who in the past are used to just walking around with a script of steroids, and they start popping them, willy-nilly. And before you know it, they've had sort of multiple courses before they actually come in, and getting those patients to be using their inhalers properly and stepping them up can be quite challenging.
And I think that's right, because I think the patients over the years have had an expectation, I'll just have another course as prednisolone, and I feel really good when I'm on it, it fixes me up. Without recognition of the long-term side effects. I mean, obviously that patient I presented, Mary, she was clearly getting side effects with every course, but for the majority of patients, I think, it'll work well, but not thinking 10, 20 years down the track and their crush fractures and all the other harm that goes with it.
Yeah, I think that they can be quite challenging. And I was just wondering about the azithromycin. What sort of doses are you using for those patients?
It's 500 3 times a week. You can drop it. There's some evidence for 250, but generally it's 500, and it's been shown in asthma to improve control in both patients with Th2 and non-Th2 pathways. So particularly the chronic bronchitis with recurrent exacerbations. We're always quite keen to take a lot of attempts to exclude atypical mycobacteria before we embark on a macrolide, because that's one of the mainstays of treatment for MAC infections. So we'd hold off in that regard. And obviously the concerns about cardiovascular side effects and checking the ECG and the QT interval after initiating therapy, but that'd be the doses. So the big asthma study was centred through Newcastle, and it's called AMAZES, but it was beneficial for asthmatics. We tend to use it also in COPD patients, not across the board. It's used more widely in bronchiectasis, but if COPD bronchiectasis overlap, we'd be thinking with recurrent exacerbations, they may benefit also. Even with it Pseudomonas, it may just help for some of its anti-inflammatory effect.
Interesting. And the patients who we think that, we've kind of in GP land done everything we can do and we've maxed out their inhalers, how, for the patients that we're going to refer in for consideration for biologics, how long is the wait for those patients to be seen? Do you know at the moment what we're sort of looking at?
If it's biologics for asthma, I'm probably looking into, it's about the 3-month mark. There's we tend to try to sort of curate the clinic pretty, so if somebody's been in ICU, we'll try to squeeze them in. We're very well supported by our asthma nurse, so she'll, often we'll ask her to call patients and do additional things in the meantime, or get information about their steroid burden. There are some rules about biologics, so that they need to be known to us for a certain amount of time before we're allowed to start. So that's one of the challenges with the rules of the PPS. Sometimes we'll get them in, if they've had an admission under respiratory and maybe some lung function tests, but we don't get to see them for a few months, then I'd still count from their admission or from their lung function date. So we try not to lose time that way.
Yeah, so I guess it's progressing them through the system.
Yeah, and not every asthmatic ends up in our asthma clinic, but the referrals that we get say, poor control, I've maxed out their inhalers, they're needing, several courses of steroids every year, I would definitely channel them straight to our asthma clinic. The ones I'd put in our more sort of lower stream general respiratory would be more of the patients that have been admitted under us who weren't using inhaled therapy, who've had an attack, and then we think we can probably just get them under control with inhaled therapy, and we reserve our asthma clinic to the more severe end of the spectrum. And that's the same with our ILD clinic. So we'll have a lot of patients with pulmonary fibrosis, but they won't all end up in the ILD clinic for access to antifibrotics and complex immunosuppression, stuff like that. So we do sort of stream the referrals according to, or stream the patients according to the information provided.
Yeah. Okay. So the more information in the referrals and responses to different treatments, the easier it is. All right. And for GPs who wanted to refer for spirometry, are we happy to have them referred in?
Sure.
Yeah. Okay.
I think certainly if people don't have access to our lung function request form, we can share it with Yvonne, to send that out. If you just want direct spirometry without clinic, it's probably easier just to send in a lung function request form.
Yeah, I think it's on the website, but we'll just make sure.
I think
Yvonne,
I'm not sure. Yeah, it's a good question. Because I think sometimes the referrals are not quite clear as to whether they just want lung function or clinic and lung function. So if it's purely lung function, then it's probably best to go straight to the lung function lab and avoid the clinic triage process completely.
Yeah. Well, and I guess, if we can refer in for lung function, then we can be doing that while we're waiting. Because I guess that's also helpful because you'll have that information as well.
Yeah.
Question here, can asthma be diagnosed without spirometry being done for the patient?
Yes. So as I said before, because it's variable airflow obstruction, it may be normal. So the other ways we would think about it would be serial peak flow monitoring and looking for an excess peak flow variability. I think you do need some measurement that there's variable airflow obstruction, but we'd often, if we're struggling for diagnosis, we would lend a peak flow meter to the patient for a couple of weeks to do some recordings, things like that. It can be, you can get biologics with a 2-specialist agreement. We tend to use that if we're really struggling, but we prefer to have some measure.
And I guess the drug companies used to give out peak flow meters all the time, but I don't think that's sort of happening as much. But they're
COVID's not helped that really.
No, reasonably cheap to buy. So
so we tend to give them to the patients, get them to do the measurements, and they keep them, and they can use that for their action plan.
Yeah. Does anybody else have any other questions? Anything that's pressing? No? Okay. Well, I just would encourage everybody, before we thank Anne-Marie, that they provide their feedback to us. We really like to hear how the session was for you, if there's anything else you would like us to cover, and any other sessions, because we're always looking to try and meet people's needs. Obviously, we try and pick things that we know that, you know, we may have long waits for at the hospital, or we think that we've got some new guidelines that we wanted to tell you about. We'll try and pick topical like that. We do have some upcoming sessions. So in August, we've got a session on heart failure and another one on gynae endometriosis topic. September is the maternity shared care workshops through the Shared Maternity Care Collaborative. And in October and November, we've got a couple of diabetes sessions. And then I'm also looking at some dermatology and pediatric asthma. So it's going to be a busy sort of second half of the year, but we'll keep trying to keep you updated with our sessions. I'd like to thank Anne-Marie for the fantastic update tonight. It was very detailed and we had her talking for a long time. So now she needs to go home for a rest. Like I said, Yvonne will send out the slides with a link to the presentation and resources. So, and also she'll include the links, if anybody hasn't seen them, to the Royal Melbourne did some sessions on the lung cancer screening program and pulmonary nodules, which will be helpful to combine that with Anne-Marie's COPD asthma. So you'll have a bit of a respiratory update with those 3 sessions. Because I think we're going to have patients that are going to come in and we'll need to be looking at all of those risk factors. So this update's been very timely. So thank you, everybody, for your attention this evening. And thank Yvonne for the support behind the scenes. So thank you.
Thank you.
Good night.
Bye.